So we have a patient that is on dialysis that's quite fluid overloaded or positive balance. So he's on dialysis to remove some of the fluid, 4 liters. There was 3 liters removed yesterday. So over here is what we were starting at. I put the regions of interest on quadrants. So this would be the right upper part of the lung, the anterior part, the dorsal on this side, anterior dorsal. We often refer to ventral to dorsal. But anyways, all to say it was ACPC. There was a PEEP of 10. There was a peak pressure, like the pressure control, was set at 30. So that's a delta of 20. And 60% FiO2. So this is what the baseline here. So we see that it's poor distribution in the dorsal, in the mid dorsal on the right side, horrible on the left side as well. Because we already have a PEEP of 10 and a delta of 20 with a peak pressure or a plateau of 30 because we're in ACPC, we're kind of maxed out. Like if I wanted to keep the delta 20 and then after put a PEEP of 12, that would bring to 32 and it would staircase up above 30. I tried briefly to increase the PEEP. Obviously it didn't do much, so I decided to try APRV. So this is what we started with. This is where we're actually at currently, which is great. Look at the difference. There was no ventilation hardly here. Now we've recovered a bit here, and it's horrible here. And look how improved it was here. And what you can do is you can look at the regions of interest. So the blue, the 54, the 25, the 14, and the 8, those are percentages. So that 660 that you're seeing right here, 43% is going to the right upper quadrant, 30% here, 11 and 16. Ideally, when we're looking at quadrants, we want the lung to be the most homogeneous. So we're expecting 25% of the tidal volume to be distributed in each quadrant, right? It's different when we do ventral, mid-dorsal, and dorsal. Those are different percentages. Usually it's 8 to 15 on ventral and dorsal, 35 to 40 in the middle section. But for this one, it was really quadrants that we're looking at. So like I said, we want to get as close as possible to 25 everywhere. So this was 54 up here, so there was a lot of it going here, right? And then after 29 here. So the majority of the 54 and the 25, I mean, that's 60, 70, 79? 79% of the volume is on the right side. 79, so only 20% of the volumes going on the left. That is a huge burden on the alveoli. So what happens is we were playing with the ACPC. We're obviously the plateau was 30, and we were getting volumes around 350. I had previously opened up the lung and maintained it open with APRV, but he was switched back to ACPC. The volumes then basically were half. So obviously the thought in our head is, wow, there's probably major de-recruitment. We had seen on the CT scan earlier that there was dorsal collapse. Now it was a baby lung effect, but from the collapse, it wasn't ARDS. So because when we're looking at a conventional road, right? So in ACPC, yeah, for sure, you have your pressure control level and you have your PEEP. So in conventional ventilation, we have control over pressure. But unfortunately, we're limited, right, with time, because in ACVC, ACPC, we have inspiratory time, 1 second often. People don't like, a long inspiratory time on a control mode. So often with ACPC, we're limited to an inspiratory time, 0.8 seconds. So we know that recruitment is pressure over time. That's why we've developed recruitment maneuvers when using conventional mode. So recruitment is pressure over time. But in conventional mode, you can manipulate pressure, but you're limited by time because of the inspiratory time. With ACPC, we have a P-high setting. So we have also control over pressure, but we're able to extend time well beyond 1 second or 0.8 seconds. And because of this, you are really increasing the chances of recruitment. It's not always about a certain pressure exerted. The pressure has to be exerted, obviously, right? But sometimes it's not a question of more pressure to open the lung. It's a question of that pressure being exerted for a longer time. As we know, time constants, right? If we remember looking at time constants, because the lung in general, especially when we have a patient that's intubated, there's going to be varying time constants. Sorry about that, like white light there. I don't know how to turn it off. Let me see. Good. That would have been nice to do that. What we did is we transitioned from the plateau of 30 to a P high of 30. Then after I increased as in a way of recruiting, a recruitment maneuver using the APRV. So I went to 32 and I stretched the T high 30 seconds. I went to 32. Waited a bit and creeped it up gradually up to 40. Obviously, I'm looking at the dynamic images in real time to see how it's reacting. What I was also doing, and I have some images as well as I'll print some stuff up and I'll be able to put it on the video. The whole time that I'm going above what we would consider 30%, 30 as a plateau above that would be not protective. But we have to take into consideration patients that are like 13 liters positive. We have to take into consideration the pleural pressure, the transpulmonary pressure, and I don't have a transesophageal balloon to measure the pleural pressure, but with the Palma Vista, you can get regional compliance. So if I was on an island and I had a choice between transesophageal balloon pump to get the transpulmonary pressure or the Palma Vista, I would choose the Palma Vista. Over here, these are impedance curves, and usually the impedance curves signify recruitment. If these impedance curves are going higher, it means that you're recovering lung volume, and in a way this black section represents a recruitment of the functional residual capacity. But when you are on dialysis, because dialysis is removing fluid from the body, right? 4 liters today. What happens is air creates a lot of impedance. So when there's air, there's more impedance, and when there's less air, there's less impedance. And this is, 50 frames per second is taking all these impedance values, and this is how it's creating the computerized image of the distribution of ventilation. But if you have fluid, that has zero resistance. There is no impedance to that signal. Therefore, fluid causes a negative impedance. And when you're removing fluid, that means that you're removing the negative impedance, and you're creating, as the water comes up, more and more impedance as you dry out. And it will interpret that. When you're looking at functional residual capacity measurements, this is typically, just give me a second. This is typically when you see these things going up, it's telling me, oh yeah, there's recruitment, great. But that's not true when you cannot trust these impedance values and any of the trending here while fluid is being removed. So this is just fluid. So careful with dialysis. Not everybody knows that, and but you can trust obviously the images, the percentages. I was continually when I was doing the titration, when I was going from 30 right up to 40 gradually. I did 30 to 34 with the Palma Vista. the electrical impedance tomography to do a P-high trial. I used the custom analysis instead of the PEEP trial. And from 30, 32 to 34, 34 was the best. So then after doing that test, what I did was, okay, well, if 34 is the best, I'm going to slowly go to 38. So I did 36, 38, did the customized analysis here, and I could see that the compliance was continually improving. So with this machine, you can individualize the therapy, and you can see what the changes that you're doing. You literally have eyes inside the lung. You can see things happening in real dynamic fashions. You can measure regional compliances, conduct analysis. Let's put this over an hour and a half. These are trends. You can refresh. You can put these regions of interest. You can add. You can remove. You can put it wherever you want. So yeah, it's been 4 hours. So this here, this pink line, that's the P-high level, and you've noticed that it hasn't changed at all. But prior, I was able to compare ACPC, then I was able to compare, just one more. I was able to compare all the varying changes. All right. Yeah. Okay, so over here there's slight improvements, but I rather wait. What I told them was, let's wait till the fluid's removed. We did our best while the fluid was being removed, and then I'll do one last P-high trial, and we'll set it there. And then I'll recommend in the medical orders, and the doctor can co-sign the range, the safe range. Okay, so that's pretty much it. We have also the inspiratory trending here, but I'll be able to show you, because it's been so long that I can't compare you the first image. But this, we could compare images, and it always compares this to this. So let's say if there was like less volume here compared to here, then it would show up orange. If there was more volume here compared to here, more volume here compared to here would be blue, and less volume here compared to here would be orange. So orange, when you're comparing, you always have to compare two. The orange means less than the other one or more. But yeah, I think we've come a long way from here. This was done almost recovery within 15 minutes, and it's gradually improving. The white that is within the blue, all it's telling you is that there is, of the tidal volume, there is more, the majority. It tells me that a lot of volume is going here. All the blue is tidal volume. That's distributed, but there's also more here. But you know that there's a distribution that's coming down, and as the lung opens up over hours, you're gonna get a nice smoothing out. This will become less and less intense. Now, you should evaluate the white area, whether there's over distension by doing regional compliance, looking for orange. There's no orange there. Yeah, so I was saying, like, you should be evaluating. So what it's saying is there's 662 tidal volume going in, but these alveoli are dealing with a lot more of that tidal volume than, let's say, this location and others. Like I said, these are percentages, so you can multiply 662 by 0.42 by 0.28, and you can know of the 600, 42%. So you can even know right down to the tidal volumes. You can also customize the squares, and you can put a square right here and just analyze certain regions as well. What else can I say? I mean, things are going really well. Like, we only had 8% in this small area, and then we're getting to 17%. And what we really want is ideally to have 25% in all quadrants. It's a big difference. We're starting to win back. This is 60, 70, still a lot more on that side. But so this is the deal, guys. When conventional ventilation does not work, even with the optimal PEEP, it doesn't mean necessarily that the patient is non-recruitable. It means they're non-recruitable on a conventional mode for that particular patient. But it doesn't mean that they are going to be non-recruitable when you start accessing the variable of time. All right, thanks. All right, so here are the results of the electrical impedance tomography P-high analysis while I was doing the recruitment phase. You see that orange little triangle there. That's the first two we're in ACPC with those parameters that we mentioned, and then after we jump to APRV, P-high of 30, there's a little bit of over distension, very, very minimal, and then after we bring that right up to 38, and that's the third where you see all of a sudden an intense orange. Now that intense loss of compliance was required to overcome the collapse, to be able to open it up. So that's a risky part, but I mean, recruitment phases are always slightly risky. But I think that if I'm guiding with the electrical impedance tomography, analyzing those regional compliance, I didn't just go blindly from 30 to 40. I was assessing compliance. We took that little risk to really decrease that compliance, but it was successful in opening up. Then you could see all the compliances improving. And that's represented by that blue line increasing. And there's numbers that correlate with that, and those are the percentages of improved compliance. So I want to kind of just review the main core principles that I want to pull out of this specific case study. So when the patient was on the ACPC, PEEP of 10 was the optimal one, and the plateau was 30. So it was giving a drive pressure around 20. Without the Palma Vista, we wouldn't have really known that more than 50% of the lung had collapsed due to the excessive fluid balance. Dialysis was required as well daily, and this made it very hard because of the fluid balances altering obviously the compliance and the mechanics of the lung. So the issue here was that ACPC, with what would be considered protective lung parameters, right? So the tidal volume was like 300, which is probably like 5 cc's per kilogram. The plateau, the pressure control is the peak inspired, so the plateau was 30. So we're doing low tidal volume, we're doing plateaus under 30. Unfortunately, couldn't reduce the drive pressure below 15. It was at 20 because the tidal volumes would have been minuscule. Already 300 is very, the Palma Vista 500, the electrical impedance tomography, we can put this non-invasive monitor that will give us dynamic images in real time as we do various parameter changes on the ventilator. We'll have immediate feedback of what is happening and how the manipulation of our parameters is changing and altering the distribution of ventilation with the Palma Vista 500, whereas we're also able to test out regional compliances. As we all know, the lung is very heterogeneous. The alveoli are not identical. Therefore, it's very useful, especially when you're in the recruitment phase, where maybe you're pushing for some higher pressures to open up the lung. We have protocols, that go, 40-40s. Some people do incremental peeps with a drive pressure of 15. We can have people that go up to 45. I've seen in a Toronto hospital up to 60, which is, wow. That in ACPC, we were within protective lung parameters, except for maybe the delta P was high, but that was the best that we could get. Any increase in PEEP above that didn't help, didn't add any volume whatsoever. So that was basically the best we could get with conventional modes. As I just said before pressing pause, conventional ventilation uses inspiratory times. While we have good control over the pressure aspect of recruitment, we are limited with the inspiratory time. Hence why people have developed recruitment maneuvers to use pressure over time. That is what recruitment is, not only about pressure. Sometimes that pressure doesn't need to be increased, but it has to be exerted for longer periods of time. If I am unable to get a good result with conventional ventilation while I'm using the Palma Vista, then I will change to APRV, and I will do the recruitment phase with APRV. And what I'll do is, let's say I'll test 30, so I'll extend. I can do just a traditional recruitment, 40-40, and then after I put them on APRV, I'll put a T high of about 5 seconds, and then after I'll test 30, 32, 34, or if we're at 26, like whatever, I'll start 2-3 incremental increases by 2. Then I'll do a customized analysis. I'll look for any over distension, any improvement in compliance. Okay, there's over distension already shown when I went up from 30 to 36. I know not going to do that. There's over distension. There's also important to realize when we're trying to reopen a lung, there might be a requirement to put a little bit of excessive pressure that will be a reading on my electrical impedance as a decreased compliance, and that will be a risk. It's saying, oh, there's a loss of compliance with this change. Is there over distension that you should be taking into consideration, right? When we're doing a recruitment, in this specific example, went to 30, 32, 34. The compliance was best at 34, continued 36, 38, compliance best at 38, continued 38, 40, best at 40, stopped there because the lung was able to be opened up. Checked, no over distension. The tidal volume started with 3, right? 300, with over half of the lung collapsed. Most of the lung was up in the right, the right anterior aspect, the ventral area, where that's not the gravity dependent areas and stuff like that. Those were collapsed previously, so we did open up. And then after this was being done on top of it to confuse everyone, it was being done when some fluid was taken off. So that I was looking at the optimal PEEP, and as the fluid was coming off, I was going down. But the tidal volumes increased to 600 from 300, and that increase from 300 to 600 was obviously when we recovered half of the lung that had been closed. So that's how I used the recruitment. By the end of the shift, the patient was now on 30, okay, except now they're on 30 with volumes of 600, which was 8.5, sometimes 9 cc's per kilogram. APRV is kind of cool when you have an extended T high, and you look at the volumes. Say they're 350, and then you come back, in an hour or two, and they're 400, and they come back, and it keeps on going up, unless there's a drastic change in the lung. We know we're doing the same pressure in the same time, and all of a sudden, every time we come back, there's more and more volume when we release momentarily to that lower aspect of APRV. So it gives you good feedback. Oh wow, they're recruiting. As the lung mechanics improve, when you're using the V500, the Draeger V500, they have auto release on the APRV mode, where we set the P low at 0, and we do measurements to stop that release from the P high to that second P low, that pressure, that second lower pressure momentarily. What we do is we stop the release when the expiratory flow goes to 75. It's a very brief release. So even if you're putting the P low at 0, the 75%, the flow, as it decreases to 75, it pops right back up. It never goes to 0. And the research done by Dr. Nadir Habashi, Gary Neiman, you can get those. You can get those on YouTube. These lectures, Nadir Habashi, Gary Neiman. You can write Draeger. So there are a lot of Draeger, obviously Palma Vista 500, right? What else here? Yeah, so for the APRV, the benefit of putting a 0, the P low, is that when it releases, there's no resistance. It's like straight to ambient. It's not going through a resistance like a expiratory valve to create a positive pressure, narrowing it, or anything like that. So by doing that, you have a P low at 0. You have the best pressure gradient to create the best flow to evacuate as quickly as possible, and then we bounce back up. Since that technique was patented, time-controlled adaptive ventilation, since that was patented and used, we don't get the traditional CO2 retention, that permissive hypertension requirement that we would often require. Because if you're setting your P high and you're actually setting a P low, that release will be very slow. It'll be slowed down because of the P low is set. So that's a resistance. So it's a big difference with the time-controlled adaptive ventilation protocol.